welcome to our ASCO 2021 roundtable discussion, where we'll cover several of the highlights of the more important abstracts for several common cancers. I'm Dr. Jack West, and I'm a medical oncologist and associate clinical professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area. I also have a particular focus on lung cancer, and we'll be covering some of the more impactful presentations in that field today. Let's turn to Dr. David Ilson, who is an expert in gastrointestinal oncology at the Memorial Sloan Kettering Cancer Center in New York, to cover the key findings at ASCO 2021 in GI oncology.
All right, well, thanks very much for inviting me to review, I think, exciting, potentially some practice-changing studies that we saw in gastrointestinal cancers during the ASCO meeting given virtually in 2021. The theme in advanced disease and upper GI cancers was the advancement of immunotherapy drugs really to first-line treatment. And we saw an interesting data from China in a large trial in esophageal squamous cancer, combining the anti-PD-1 antibody camaralizumab added to chemotherapy with paclitaxel cisplatin versus paclitaxel cisplatin alone. And the trial met all its endpoints with improvements in progression-free and overall survival, as well as an improvement in anti-tumor response rate. And it was interesting that the benefit for this drug was independent of PD-L1 status, that PD-L1 less than 1% patients were showing a similar benefit to PD-L1 1% or higher. So I suspect this drug will move forward in China and potentially Asia. The other very exciting study was moving Navalmab into first-line chemotherapy in metastatic squamous cancer of the esophagus. This was actually the largest global trial and one of the first global trials ever conducted in squamous cancer of the esophagus, treating over 900 patients. And this was a trial of Navalmab plus chemotherapy with Falfox, chemotherapy with Falfox alone, or a non-chemotherapy arm combining Navalmab and Ipilimumab. And this trial also met its endpoints of improving progression-free and overall survival. Basically, they looked at TPS scores of PD-L1 and looked at less than 1% versus 1% or greater. And they did show in the PD-L1 positive patients, as well as all patients, improvements in overall survival, progression-free survival, and response rate, and met the primary endpoints of the trial. However, if we look at the breakdown by PD-L1 status in patients that had PD-L1 scores that were less than 1%, the hazard ratio for benefit approached 1. So it really depends on how you look at the data. I mean, if you look at all patients, which includes PD-L1 negative and positive, there's a benefit, but it seems that the benefit is mainly in patients that were PD-L1 1% or higher. Also interesting was the non-chemotherapy arm on this trial, the combination of Ipilimumab and Navalmab versus chemotherapy. So despite on this trial not showing a better progression-free survival for the non-chemo combination, overall survival was improved, as were response rates. So there was actually a little bit of early drop-off in patients, maybe up to a 5% higher death rate for the Ipi-Nivo compared to chemotherapy, but that was counterbalanced by better survival, better response, better progression-free survival. So it may be, in addition to Navalmab moving forward in the first-line treatment of metastatic squamous cancer of the esophagus combined with chemotherapy, in selected patients, if there is regulatory approval, there might be consideration for the first use of a non-chemotherapy arm in advanced squamous cancers of the esophagus. We also then had updates of another important trial, Navalmab plus Falfox in metastatic gastric cancer. The investigators showed improvement in quality of life. There was a slower decline in quality. This is already a positive trial for Navalmab added to chemotherapy in the first-line treatment of gastric cancer, with improvements in progression-free overall survival and response rate. And they also showed that the decline in performance status was slowed with this combination. Again, benefits for nivolumab did seem to be dependent on PD-L1 status. They looked at both the TPS score, which looks at just the PD-L1 in the tumor, and then the combined PD-L1 score, which looks at also at macrophages and lymphocytes. And again, if you look at the patients that were CPS high, there was a clear benefit. But when we see the patients that are CPS less than 5% or CPS less than 1%, hazard ratios started to approach 1. So again, the benefits for these drugs may be more strongly seen in the CPS positive patients. And already in the United States, we have approval for nivolumab in gastric cancer first line combined with Falfox, irrespective of PD-L1 status. And we also have approval for the drug pembrolizumab in adenocarcinoma and squamous cancers of the esophagus combined with chemotherapy first line, irrespective of PD-L1 status. The other important update was the Checkmate 577 study. We recently had FDA approval in the United States for adjuvant nivolumab in patients with adenocarcinoma or squamous cancer of the esophagus. If they go through chemotherapy, radiation, and surgery and still have residual disease remaining at surgery, adjuvant nivolumab is now approved as adjuvant treatment. This was based on a doubling of disease-free survival from a year to almost 2 years. And the investigators updated the results and showed also that a year of nivolumab did not negatively impact quality of life in patients that got this treatment, and there were no new safety signals. So yet another practice-changing trial and another FDA-approved indication. Another important study, lots of important studies in esophagogastric cancer, was the Neo-Aegis trial from from Ireland and or other European countries. This was a trial conducted in esophageal cancer and GE junction cancers, adenocarcinomas. There's an ongoing debate whether we should give these patients chemotherapy and radiation followed by surgery or just perioperative chemotherapy alone with a regimen like FLOT. So this was a well-conducted study, adequately powered, where they compared chemoradiation, carboplatin, paclitaxel radiation followed by surgery versus the older standard chemotherapy, which was the magic regimen of EOX. So EOX chemotherapy given perioperatively versus chemoradiation with carboplatin, paclitaxel, and radiotherapy followed by surgery. Patients were well staged. All patients had PET scan. All patients had endoscopic ultrasound. The investigators did central radiology review of the radiation plans. Also, the surgeries were done in centralized centers, so it very good quality control of the surgery. And interestingly, there was no difference comparing chemoradiation, carbotaxol radiation followed by surgery versus the 6 cycles of EOX chemotherapy. No difference in 3-year overall survival, which was 57% in both arms. And actually, both arms actually performed better than was expected with this trial. So the debate is ongoing. Should we give these patients chemoradiation followed by surgery or chemotherapy? I will say that the chemoradiation arm, all the pathologic endpoints were superior. Patients had higher pathologic complete response rates, higher rates of curative resection. The curative resection rate was increased into the 90% range for chemoradiation, and more patients were node negative. And all of those pathologic features tend to favor better survival. But despite that, there was not a survival difference between chemoradiation versus chemotherapy. So now the question is whether a better chemotherapy regimen like FLOT, which is the new standard, that's 5-FU oxaliplatin docetaxel, which we already know is better than EOX for perioperative chemotherapy, whether the FLOT regimen will be as good or better than chemoradiation with carboplatin, paclitaxel, and radiotherapy. My read of the study, however, is given the equipoise of chemoradiation versus chemotherapy. I just mentioned the adjuvant nivolumab data, which substantially improves disease-free survival after chemoradiation and surgery. So for esophageal cancer, my preference, given the now shown benefits for adjuvant nivolumab, would be chemoradiation surgery and adjuvant nivolumab. And I'll just mention briefly two interesting studies presented in hepatocellular cancer from China. Both of these looked in, one trial looked in unresectable liver metastasis, comparing sorafenib versus intra-arterial chemotherapy with Falfox. Intra-arterial chemotherapy was superior on this trial. It resulted in higher response rates, progression-free, and overall survival. And although this was an interesting study, we now know that sorafenib is no longer the standard in hepatocellular cancer. Now the standard of care is atezolizumab plus bevacizumab. So it's kind of hard to look at this approach of intra-arterial chemotherapy now that we have a better standard chemotherapy in this disease. And then the other study from the same center in China looked at intra-arterial Falfox in resectable hepatocellular cancer, looking at immediate surgery versus intra-arterial chemotherapy first, followed by surgery. This also was a positive trial indicating potential improvements in overall survival. There was about a 10% per year improvement in survival with intra-arterial chemotherapy given preoperatively. The criticisms of the trial, it was mainly done at one center, and you could argue some of the patients that they selected had Barcelona B subtype liver cancers, which may not be optimal surgical candidates. So some of these patients may not have been best candidates for surgery, but provocative data that we need follow-up. Briefly then, just to finish the tour of the GI tract, I just want to comment on some important studies presented in colorectal cancer. One of the most anxiously awaited was results of the Keynote 177. This was in MSI-high colon cancers comparing chemotherapy with pembrolizumab versus chemotherapy. We already know from initial data presentation that progression-free survival, response rate, duration of response were all dramatically better with pembrolizumab compared to chemotherapy. And this study now presented survival data. The survival data trended to favor the pembrolizumab. And in fact, median survival in the pembrolizumab arm was not reached compared to 37 months for chemotherapy. So it certainly trended favoring pembrolizumab, and we now know that pembrolizumab is the new standard of care for upfront treatment in MSI-high metastatic colorectal cancer. One of the confounding factors is about 60+% of patients crossed over to get immunotherapy. So that always undercuts the survival benefit when patients cross over to the experimental arm. But certainly the data reinforce that pembrolizumab or checkpoint inhibitors, metastatic MSI-high colon cancer should be the standard of care as first-line treatment and are superior options to chemotherapy. Then I'll just mention briefly a few maintenance therapy trials. There were trials looking from Great Britain in patients getting upfront chemotherapy and then randomized to capecitabine maintenance versus observation. As have all these maintenance trials or observation trials have shown, active treatment or more intensified treatment always results in improvement in progression-free survival, but not a clear survival benefit. So this trial from Great Britain, capecitabine versus observation, the Focus 4 trial, does support careful observation off treatment in selected patients. You might lose on the progression-free survival, but you don't lose on overall survival. Then there was another randomized trial on patients that are RAS wild type that were getting upfront EGFR targeted therapy with chemotherapy plus panitumumab. Patients were then randomized to maintenance therapy with 5-FU alone or 5-FU plus continuation of panitumumab. And again, similar to other studies, we get a better progression-free survival with combination maintenance versus single agent, but no clear survival benefit. And arguably, continuing the EGFR drug may enhance toxicity. So then there were other interesting trials in the first line. We know that BRAF mutant colon cancers have a more aggressive biology. They don't respond as well to chemotherapy. And we suspect that they have intrinsic resistance to EGFR targeted therapies, just like RAS mutant tumors. So the French did a randomized trial in BRAF mutant patients of FOLFOXIRI triplet chemotherapy combined with bevacizumab or combined with cetuximab. Not surprisingly, we know that BRAF mutant patients are resistant to EGFR targeted therapies, and the cetuximab arm was inferior at all measures to the first-line bevacizumab arm. And many of us consider either Falfox bevacizumab or Falfoxiri bevacizumab as standard first-line treatment for a BRAF mutant cancer. Now, that doesn't mean that EGFR inhibitors aren't used in later line treatment. We know that in BRAF mutant patients, if we combine a BRAF inhibitor with a cetuximab, that's an active treatment. So a combination of a BRAF inhibitor plus cetuximab is actually quite active in later line treatment and also overcomes the resistance to the EGFR targeted therapies. I think with that, I'll close. Really a very exciting session. And reinforcing some of the knowledge that we know already, and also hopefully indicating directions of future study.
Dr. Aditya Bardia is a breast cancer expert at Massachusetts General Hospital. He's also an assistant professor at Harvard Medical School there and in Boston, and we'll get his input now on some of the most important highlights in breast cancer from ASCO 2021.
Thank you so much for the invitation. Great to be part of this panel discussion. Excellent discussion. I will focus on breast oncology. I'll focus on a few abstracts related to both metastatic as well as early breast cancer. The first abstract that I want to focus on is based on a clinical trial called Olympia. It was a practice-changing study, the #1 abstract presented at ASCO 2021. This clinical trial looked at a drug called Olaparib, which is a PARP1 inhibitor for patients with germline BRCA mutant breast cancer. It was an adjuvant trial. Patients with high-risk HER2-negative breast cancer who had germline BRCA mutation were randomized to receive Olaparib versus placebo in the adjuvant setting. Overall, the trial was positive. It showed an improvement in disease-free survival as well as distance recurrence-free survival with the use of Olaparib as compared to placebo. And we anticipate that this is a practice-changing study which will lead to the approval of adjuvant Olaparib for our patients with germline BRCA mutant breast cancer. Not only are the findings practice-changing, it's a major development for the field as well. It's a beautiful story of how the preclinical observation of synthetic lethality translated to a phase 1, phase 2 clinical trial where objective response rates were observed with Olaparib to a confirmatory phase 3 trial, first in the metastatic setting, which led to the approval of Olaparib in the metastatic setting and now in the adjuvant setting. The second abstract relates to an ECOG accurate study 1131. The study asked the question, can we look at adjuvant platinum versus adjuvant capecitabine for patients who have residual disease after neoadjuvant chemotherapy? So it was a simple trial similar to the CREATE-X design where patients who had residual disease after neoadjuvant chemotherapy were randomized to receive adjuvant platinum versus adjuvant capecitabine. Initially, the trial was designed as adjuvant platinum versus no treatment, but with the CREATE-X data, the capecitabine arm got added on. Overall, the trial did not show any difference in disease-free survival between adjuvant platinum versus adjuvant capecitabine. So the bottom line is that the current practice remains the same. For patients who have residual disease after neoadjuvant therapy, the recommendation would be consideration of adjuvant capecitabine. The other important observation from this trial was that overall, the outcomes were very poor in both arms. There's a high risk of disease recurrence, be it patients who got adjuvant platinum or who got adjuvant capecitabine. So there's an unmet need for better therapies for our patients who have residual disease after neoadjuvant therapy in the setting of triple-negative breast cancer. A third abstract also linked to triple-negative breast cancer was from the GOPAR-NEVO trial, a European trial looking at neoadjuvant durvalumab, an immunotherapy agent in combination with chemotherapy. It was a randomized study looking at combination of immunotherapy plus neoadjuvant chemotherapy versus neoadjuvant chemotherapy for patients with localized triple-negative breast cancer. Initially, the results had shown improvement in PCR with the addition of immunotherapy as compared to the no immunotherapy group, but the improvement in PCR wasn't marked. At Virtual ASCO 2021, we saw the results of disease-free survival, and you could see both the clinically meaningful and statistically significant improvement in disease-free survival in patients who received immunotherapy as compared to the other group. So these data, along with the press release from Keynote 522, which was a trial that looked at neoadjuvant and then adjuvant pembro with chemotherapy versus no immunotherapy, the press release showed that the addition of neoadjuvant pembrolizumab and then adjuvant not only resulted in improvement in pathological complete response, but also a disease-free survival. So the combination of Keynote 522, we've not seen the full results, but based on the press release as well as the GOPAR-NIVO, just gives additional confidence about the use of immunotherapy in patients with localized triple-negative breast cancer, and likely would change the field, and we'll be seeing more usage of immunotherapy in this setting. Now, shifting gears and talking about metastatic hormone receptor positive breast cancer. At Virtual ASCO 2021, we saw the updated results of overall survival related to CDK4/6 inhibitors, palbociclib and ribociclib. We saw the updated results from PALOMA-3, which was a second-line and beyond study in patients with hormone receptor positive metastatic breast cancer, randomization to fulvestrant plus placebo versus fulvestrant plus palbociclib. This has been a practice-changing study that led to the approval of fulvestrant plus palbociclib. At ASCO, we saw updated overall survival results, and there was a signal towards improvement in overall survival with fulvestrant plus palbociclib as compared to the control group, particularly in patients who had endocrine-sensitive disease or patients who had not received prior chemotherapy. We also saw results from MONALEESA-3, which was a similar design to PALOMA-3, that it looked at a CDK4/6 inhibitor, ribociclib, in combination with fulvestrant, but was different in the sense that it was a first-line and second-line study. So in the first-line, second-line study, asked the question fulvestrant plus ribociclib versus fulvestrant plus placebo, a positive trial which led to the approval of fulvestrant plus ribociclib combination, showed an improvement in progression-free survival, and we had previously seen improvement in overall survival. We saw updated results at ASCO continue to see an improvement in overall survival with the combination of fulvestrant plus ribociclib. So it gives confidence in the use of CDK4/6 inhibitors, and in my opinion, CDK4/6 inhibitors with endocrine therapy should be considered as the first-line regimen for patients with metastatic hormone receptor positive breast cancer. So then how about second-line and beyond? At ASCO 2021, we saw a couple of abstracts that addressed the second-line and beyond setting in patients who had received prior CDK4/6 inhibitor. The first one was the Veronica trial, which looked at fulvestrant in combination with venetoclax, a BCL2 inhibitor, as compared to fulvestrant without the BCL2 inhibitor. Overall, it was a negative trial, did not show any improvement in progression-free survival or overall survival. So it's unclear that BCL2 inhibitors would have a role, particularly in the later line setting. It's possible that these drugs have a role in earlier lines, but definitely based on the Veronica trial, the role in later line settings is unclear. A couple of abstracts related to oral selective estrogen receptor degraders, or SERDs, one being giredestrant, another being amcenestrant. And the bottom line being that these oral SERDs have activity, single agent activity, activity in combination with palbociclib, and we're going to see more and more results related to these oral SERDs in the future. And then finally, I want to close with a very interesting abstract that was presented by a patient advocate, probably the first time at ASCO in the breast session that a patient advocate presented results in an oral symposium format. The abstract was looking at this question of patient-centered dosing. And Losser and her team surveyed more than 1,000 patient advocates and asked them about how they feel with oral drugs in the setting of metastatic breast cancer. Have they had side effects? Have they discussed their side effects with physician, and how their quality of life is? Majority of patients had some side effects related to oral medications. Some needed ER visits. Patients needed dose reduction. And in general, patients who had a dose reduction felt better with the lower dose. So it brings into this question about what's the right dose or the optimal dose that should be considered in the metastatic breast cancer setting. High dose might not necessarily be the best dose, and it's about the right dose for the right patient. And this is something that's being considered by the FDA as well. Recently, there was a press release by the FDA that FDA would discuss with industry about conducting studies that look at different dosage of the drug, so that at the end of the day, it's about the best dose and the right dose for an individual patient with metastatic breast cancer. So to wrap up, a number of important studies presented at ASCO, practice-changing study with Olympia, which will likely result in approval of adjuvant olaparib for patients with germline BRCA mutant breast cancer, excitement about immunotherapy, excitement about oral SERDs, and also discussion about what's the best dose that should be considered for a patient with metastatic breast cancer. Thank you.
Let's turn to the more provocative and potentially practice-changing findings in lung cancer from ASCO 2021. And the first I'd like to cover is in the setting of early stage, potentially curable non-small cell lung cancer, a study called Empower 010 that was presented by Dr. Heather Wakely. And this is a randomized phase 3 study that tested immunotherapy in the adjuvant setting. It was for patients with stage 1B to 3A disease who had undergone potentially curative resection and could be any degree of PD-L1 expression from less than 1% to high. And then patients had to have received some platinum-based chemotherapy up to 4 cycles, but anything from 1 to 4 cycles was potentially acceptable if patients discontinued early. And then patients were randomized at that point to either subsequent surveillance and supportive care, or in a 1-to-1 fashion were randomized to every 3-week atezolizumab immunotherapy for essentially up to a year, or 16 treatments, 48 weeks. And about a little over 1,000 patients ended up randomized to the immunotherapy or surveillance. And the primary endpoint was disease-free survival. And this was a hierarchical statistical design. So the way it was done was starting with an analysis just of patients with stage 2 or 3A disease and with PD-L1 expression of 1% or higher. If disease-free survival was a significant difference, then there was a subsequent analysis for any PD-L1 expression, stage 2 to 3A. And then if that analysis is positive, there was an analysis of any PD-L1 and stage 1B to 3A, so the intent to treat population. If all of those conditions were met, there was a subsequent analysis for overall survival. And what the trial demonstrated was an improvement in disease-free survival with the first analysis of PD-L1 positive disease, stage 2 and 3A. And the trial also was positive, but less so for any PD-L1 expression, stage 2 to 3A. The hazard ratio went from about, I believe, 0.66 in the initial more restricted analysis to 0.79 for the broader population with any PD-L1. And there was a subset analysis of the any PD-L1 in stage 2 to 3A that showed that the benefit was really very concentrated in patients with high tumor PD-L1 expression. So 50% or higher had a hazard ratio of 0.43, but the any PD-L1 population but the PD-L1 1% or higher was 0.66. And so that included the patients with high PD-L1. What we can conclude from that is that the patients with low PD-L1, 1 to 49%, must be quite a bit less impressive with a hazard ratio over 0.8 because they're essentially diluting the much more impressive improvement in disease-free survival seen in the narrower population with high PD-L1. There was also then a subsequent analysis of the intent to treat population with any PD-L1 expression and stage 1B to 3A disease, and that did not achieve statistical significance at the interim analysis, although the hazard ratio was not that different. It was 0.81 for disease-free survival. But because that did not achieve statistical significance, there was not a subsequent analysis of overall survival, and we may never get that. The side effect profile was not unexpected, was not especially high, but it is notable that patients with who get adjuvant immunotherapy can have long-term, even potentially permanent adverse effects from this. So it's not something that we should minimize. Nevertheless, the trial was positive for a disease-free survival benefit in at least patients with stage 2 to 3A disease and with PD-L1 expression of 1% or higher. Now, that was actually clearly driven by the high PD-L1 group, but I expect that we'll see an FDA approval of this, very likely for the broader population. And the question is, what will we do with this? We don't have yet an overall survival difference. I think I will be quite inclined to pursue this, certainly talk about it for my patients who are eligible, and likely recommend it for my patients with high PD-L1, but be less enthusiastic about it for patients with low PD-L1. I think it's unfortunate that we have trials designed that do not necessarily report out analyses of overall survival if several conditions are not met. And I also think it's unfortunate that we have results that are presented with a kind of Russian nesting doll design that show PD-L1 high or PD-L1 1% or higher that includes and is likely driven by the high PD-L1 group, but doesn't separately show the results for the low PD-L1 setting. Let's move on. And another question is the potential role of immunotherapy in a preoperative setting. And Dr. Spicer presented the surgical outcomes for the Checkmate 816 trial that we had seen some preliminary results from at AACR this year. This trial looked at giving 3 cycles of chemotherapy with or without nivolumab added to that in patients with stage 1B to 3A disease. It previously showed at the AACR meeting, we saw that there was a really striking and significant improvement in the pathologic CR rate with the addition of the nivolumab just for 3 cycles, going from 2.2% with chemo alone to 24% with the addition of nivolumab, and the response rate by imaging improved from about 9% to 37% with the addition of nivolumab. And this is really quite impressive, but we now got from Dr. Spicer's analysis the results based on specifically the surgical outcomes. What we saw was a little more detail about pathologic CR rates, seeing that the differences were especially pronounced in the few patients with stage 1B disease. That was a minority of patients on the trial, but the difference was actually 0 with chemo alone versus 40% in the patients with stage 1B disease. And we also saw results that showed the surgery was shorter by about 40 minutes in the patients who got immunotherapy, so no detrimental effect there. There was no difference in the time to get to surgery. Overall, there was deeper regression of the cancer on pathologic imaging, on pathologic analysis. There was more likely for patients to be able to undergo minimally invasive surgery without conversion to an open thoracotomy if they received nivolumab with the chemotherapy. This was particularly true for the patients with stage 3A disease, who we might envision to be kind of on the bubble for needing an open thoracotomy. They were also less likely, if they received nivolumab with chemotherapy preoperatively, to undergo a lobectomy rather than a pneumonectomy. There was no difference in complications. If anything, there was a decrease in the levels of pain in patients on the nivolumab arm, likely related to the less extensive surgery that was required in a subset of patients. And so overall, what we have here is further evidence to show that there's certainly no harmful clinical effects from the addition of the immunotherapy. If anything, many of the variables that we look at in surgical outcomes were more favorable, some significantly so, with the addition of immunotherapy to chemotherapy. In terms of what this means, we don't have an approval yet for preoperative chemoimmunotherapy, but we're going to see more work on this. This particular study was a phase 3 trial, 358 patients. And I think it will be helpful to see clinical outcomes like event-free survival and eventually overall survival. But these differences are very striking. And I think this, combined with the Empower 010 trial, will highlight that we are going to likely be incorporating immunotherapy more and more for patients with resectable disease. It remains to be determined what the best way to do that is going to be. Combined with chemo preoperatively, sequentially, after adjuvant chemo postoperatively, and in which subsets. We don't have that analysis from Checkmate 816 in terms of which patients benefit most, but it's an exciting time. And in the future, I think we will be adding immunotherapy to more and more treatment plans in the early stage setting to improve the cure rates. But we don't yet have those clinical outcomes to say that. Let's turn to advanced stage disease. And one of the more interesting presentations was by Dr. Akinboro from the FDA. And this looked at a pooled analysis of data from FDA submissions and multiple phase 3 trials, and focused on patients with stage 4 disease with 1 to 49% PD-L1 expression, and whether they had received immunotherapy alone, either pembrolizumab or nivolumab with ipilimumab, or immunotherapy with chemotherapy. And this was a comparison of the data from these aggregate trials, showing that the median progression-free survival was better for the patients with low PD-L1 who received chemoimmunotherapy. The median PFS was 7.7 months with chemoimmunotherapy versus 4.2 months for those receiving immunotherapy alone. But interestingly, there was no clear difference for patients who were 75 or older. This is not a definitive result. It is retrospective data, but we don't have a great comparison in a direct prospective fashion here. And for many of us, this confirmed what we already suspected, that immunotherapy is really not a preferred approach on its own for patients with low PD-L1, in contrast with high PD-L1 of 50% or greater. Nevertheless, the fact that a subset of patients, maybe those older, particularly maybe with marginal performance status or organ function, could do just as well and be well served by receiving immunotherapy. So still a role for judgment and individualization. In terms of targeted therapies, there was a great deal of interest and enthusiasm around new treatments for different different targets. One was looking at a target that we haven't previously had, and that's KRAS, specifically KRAS G12C mutations. Dr. Skoulidis presented abstract 9003, and this looked at the overall survival results with sotorasib, a KRAS G12C inhibitor that was just approved by the FDA in late May of 2021, so just before the meeting. And this had previously shown in a New England Journal publication a response rate of 37%. This is in significantly heavily pretreated patients with stage 4 disease. 90% had received either chemotherapy, platinum doublet chemo, or immunotherapy. In fact, 80% or so had received both. So for many of these patients, it was stage 3 or later, and the response rate was 37%. The median progression-free survival was 6.8 months in this heavily treated population, and the median overall survival was 12.5 months. What we also saw was some early information about co-mutations like TP53, STK11, and KEAP1, and these findings show that patients receiving sotorasib still had good responses really across a very broad range of clinical and molecular subgroups. There hasn't been a deep analysis of these co-mutations in other settings. So how to use this information is really going to be the subject more of future research, but I think it poses important questions. Now that we have sotorasib FDA approved and commercially available, many of us are going to want to use it not just as a late line, third line, or later, but to move it into second line and maybe even first line for a subset of our patients. We need to better clarify which ones are not benefiting from chemo, immunotherapy, or immunotherapy alone. And I think that this agent and other KRAS inhibitors are likely to really change the field for a very large subset of patients. About 13% of our patients with advanced non-small cell have a KRAS G12C mutation, so really filling an unmet need here. But it is important to note that this agent is specifically for KRAS G12C, not for other KRAS mutations, G12D, G12V, et cetera, that we also may see in practice. But the field is going to move quickly here. Let's turn to EGFR mutations. And with that, we have some real hope for patients with acquired resistance to an activating EGFR mutation. Doctors Baumel and colleagues presented the results of the Chrysalis phase 1 trial of the combination of amivantamab and lazertinib. Amivantamab is a bispecific monoclonal antibody against EGFR and MET. This was combined with the third generation EGFR inhibitor lazertinib. And in the trial presented actually by Dr. Cho at ASCO, we saw a 36% response rate overall, and they did an analysis of whether patients had an acquired resistance mechanism driven by EGFR or MET. In that subset of patients, which was the minority of the 45 in the overall analysis, the response rate was 47%, compared with 29% response rate in patients who didn't have one of these mechanisms. So not clear that you would need or want to apply this selectively in just a subgroup of patients. And while this needs to be studied further, we're seeing response rates that give a lot of hope for something that could be done after patients have progressed on osimertinib, which is very helpful as a first-line therapy, but we know it doesn't last forever for patients. So more work needing to be done here, but there are other studies being planned. There's some other phase 2 data developing in the acquired resistance setting, but importantly, a trial called Mariposa, a phase 3 study that is looking at osimertinib as a standard arm versus either lazertinib as a single agent or the combination of amivantamab with lazertinib in the first line setting. That trial's ongoing, and that may change our practice in the coming years for patients with an EGFR mutation. And there was also a study presented just after that by Dr. Paseyane, number 9007, looked at patritumab deruxtecan. This is a HER3-directed antibody drug conjugate that showed a 39% response rate in patients who had received prior EGFR TKI, most of whom had received prior osimertinib, and same response rate there. There was no clear pattern of greater or lesser response rates with this agent, patritumab deruxtecan, regardless of the demonstrated mechanism of resistance. So we'll need to see more on that. But again, having more agents with potential utility in a setting where we just have not had data on what might be an option next, particularly targeted therapy options after osimertinib, very welcome news. But with that, we also got some studies showing the challenge of work predicated on good molecular testing. And one important study was by Nick Robert and colleagues. It was presented by Dr. Evangelist. Abstract 9004 looked at the US Oncology Network experience of the frequency of molecular testing in patients with stage 4 non-small cell lung cancer from spring of 2018 to spring of 2020. And what they found was, looking at rates of testing for PD-L1, EGFR ALK, ROS1, and BRAF V600E, while at least approximately 90% of patients had gotten testing for at least one of these over that time, only about 70 to 75% of patients had testing for the driver mutations like EGFR, ALK, ROS1, and less for BRAF V600E. So they did count PD-L1, which is really a different animal. And less than half the patients in this sample of almost 3,500 patients altogether had undergone testing for all 5 of these targets, which were not esoterica. These were targets that are in the NCCN guidelines with clear recommendations to do that testing, at least for non-squamous non-small cell, who were the majority of these patients. And there were FDA approved therapies for all of these. So a little disappointing when we see that less than half of the patients are getting the full range of molecular testing. And when they looked specifically at NGS testing, they saw that while the numbers improved over the 2-year period, they only improved from 33% in the first 6 months to 45% getting NGS testing in the last 6-month period, which I would consider damning with faint praise. So I credit the investigators for taking a hard look in the mirror and asking about real-world experience of molecular testing. But it really shows us that we need to do better. We have all of these great targets, but we won't be able to avail ourselves of these therapies unless we do the testing that is needed. And some people wondered whether this was just a question of not looking well enough, or maybe detecting in a chart review what findings should be there. But in fact, Dr. Bruno and colleagues did a presentation just following that, Abstract 9005, that looked at Flatiron data in more than 10,000 patients, and saw that these patients with stage 4 non-small cell had a testing rate also of just under 50% overall for molecular markers. And just for good measure, and adding insult to injury, we saw that from that data set, Black individuals had a significantly lower rate of molecular marker testing and about half the rate of participation in clinical trials. As we talk about equity in cancer care, it really underscores that we need to do better in molecular testing and racial diversity in testing and clinical trials. The final study that I wanted to highlight is of Almalertnib, another 3rd-generation EGFR inhibitor that was the subject of a trial called Aeneas. It was presented by Drs. Liu and colleagues in the poster discussion section for advanced non-small cell, obviously for advanced disease with an EGFR mutation, and comparing this agent Almalertnib to gefitinib, a 1st-generation EGFR inhibitor. This is very similar to the Flora trial that led to our broad use of osimertinib first line instead of a 1st-generation EGFR inhibitor. This is a very similar trial compared to gefitinib, and this was a study done across China, 429 patients from 53 sites in China, that really recapitulated the improvement in progression-free survival. The difference here, 19.3-month median PFS with Almalertnib versus 9.9 months with gefitinib. So very good to see The tolerability of Almalertnib seems pretty comparable to what we've come to expect and be very happy with for osimertinib. It's not a clearly superior result for efficacy or tolerability, but the hope is this is from a company that plans to bring this drug to market at a cost that's less than half that of osimertinib. Now, we don't yet have it commercially available, and we don't yet have data on CNS activity of almalertnib, which is an important added feature for osimertinib, and we also don't have overall survival. But having the promise of an agent that could be disruptive and really break the détente, the impasse we have with prohibitively high drug pricing, this could make it possible to offer a drug like these third generation EGFR inhibitors, not just in places with a lot of money to spend on patient care, but in other parts of the world, and also with lower costs to patients in the US and Europe and elsewhere. So we need to see more on this, but this is, I believe, an agent to watch and an entire concept to watch. If we could come in with drugs that are comparable to what we already have, but have much lower prices associated with them. Obviously, that's a lot to cover, and it was a very exciting ASCO 21, but I think that we're going to have even more exciting things to follow as this research and other promising fields areas move forward in the coming months and years. Thanks for your interest. Drs. Ilson and Bardia, thank you so much for your comments today on the most important findings in GI oncology and breast cancer from ASCO 2021, along with my own input on what's moving the field in lung cancer. Clearly, it's an exciting time in solid tumor oncology, as well as more broadly in hematology oncology. We'll have a lot more to cover in future programs. It's just an exciting time to be in the field. Drs. Ilson and Bardia, thank you so much for your comments today on the most important findings in GI oncology and breast cancer from ASCO 2021, along with my own input on what's moving the field in lung cancer. Clearly, it's an exciting time in solid tumor oncology, as well as more broadly in hematology oncology. We'll have a lot more to cover in future programs. It's just an exciting time to be in the field.